save you some time walking. All right, so we going to have some announcements afterwards. We have time for 3 questions. Go ahead and line up on the back, and you're welcome to or shout it out.
Hi.
Mayor, go ahead.
So I'm a parent here in Palo Alto. My name's Mayor Lucas. I lost my son to suicide 8 years ago, and we've had 3 suicides here in Palo Alto of youth in the last 6 months. So as many of you know, I'm on a quest. So question number 1 is, I know a lot of this data sets and everything like that is focused on adults, and I understand why. But are you looking at going downhill? You know, if you look at fMRIs of youth, is there a way of like predicting that forward? Because I would have loved that to have happened. So that's kind of question number 1. And then question number 2, but I don't want to hog it, be quick answers. But I also recently got past cancer, and that's like, I'll call it situational depression. And I was wondering, are you looking at some of this and working it into, like, I don't know, my chemotherapy treatment, for example? So sorry, they're widely divergent, and pick one or both.
Thank you so much. Who would like to go?
Maybe I could go first. There's no reason why the work cannot be extended to younger populations. Because I'm interested in treatment specifically, with medication treatments, there's like a relatively smaller repertoire of potential options in younger patients. And so for practical reasons, I decided to focus on adults, but there's no reason it cannot be extended to the population below 18.
Thank you.
Sorry, Mayor, I just want to say thank you so much for sharing that. And you and I really, are allied in wanting to do more for our teens, especially in this area. And I just want to commend you and keep asking those great questions. Keep insisting that we push the science border. We're a long ways to go to help our kids.
Hi, I'm Kaya. I'm in 7th grade. I'm really interested in neuroscience. Thank you guys again so much for giving these talks. My question has to do with neuroimaging and how it could possibly help with diagnoses and learning differences. As a student with OCD, I know it can be really hard sometimes to know what's going on in my brain, and I know other people go through the same challenges. I'm wondering if there's possibly a way to use neuroimaging to give more personalized diagnoses to people so they can more understand what they can do to help themselves and lower their anxiety levels. And if possible, if you see a future in making neuroimaging more accessible to the general population.
Okay, thank you so much for your wonderful question. You are the future. Thank you so much. Okay, right? Amazing question. We're going to have Eric field that one for you.
Yes, thank you for your question. That's an excellent question. I think we can expand our neuroimaging applications beyond depression and anxiety to OCD. This work just has not been done yet from my understanding, but I think there's potential for that. In terms of targeting patients with those types of disorders, that is happening. So there's studies that are happening here at Stanford and elsewhere using neuroimaging biomarkers to improve the accuracy and response rates to various treatments. A few of them are neuromodulation based, and the identification of the optimal target is what's being discussed. And whether we look at specific anatomic regions, which is the more classical approach, or maybe targeting various networks or pathways. I opted not to go into that with our talk as we focused on depression. It's more clinically kind of a bigger player at this point, but OCD is certainly up there and coming. So I think that there will be more targeted treatments going forward, and I hope that offers some hope.
Yeah, thank you, Kai. And before we go to our next question, I just want to shout out Lawrence Fung, who has a Stanford Neurodiversity program and summer camp, and my son went to it, and it was just really wonderful. So thank you.
Hi, my name is Adam. I'm an instructor in psychiatry. I have a question about the individual level fMRI circuit scores, essentially. I've been working in fMRI for a long time, and it's really exciting to see this clinical translation. People often wondered whether it would happen, and most of the fretting has been about kind of low effect sizes and retest reliability. What do you think are kind of the main methodological leaps that have happened to allow us to get to these kind of individual level scores? And do you have any concerns about reliability at the individual level?
Yeah, thank you. That's, I think, a fantastic question. I think why we've been able to translate it here is just because of some of the experts that we have, the experience they have, the trials that they've used, and our willingness to incorporate it as a component of the treatment plan and not necessarily be the be all and end all of it. And so we're correlating those measures with other measures of cognitive function and testing, and even looking to integrate, like Teddy was discussing, some maybe AI perspectives to it. I think the bar is kind of low in the sense that, trial and error is kind of the status quo. And if anything, this offers a new target or a new perspective for patients to try. And so often people are coming to us with kind of like end stage, failed everything, and they're looking for an answer. And sometimes we're able to identify something that hasn't been seen yet or hasn't been tried yet, and we have data to support it. So
that's great work. Thank you.
Nolan, do you want to have anybody else have any thoughts before we close out?
Yeah, I mean, I could answer the second comment that was brought up about cancer and treating depression with comorbid medical conditions. I think it was a good question. Yeah, I mean, I brought that up earlier, right? Which is depression makes everything, worse, both from an experiential standpoint. So like comorbid depression in a chronic pain patient makes pain sensation actually more painful, right? So it makes the condition subjectively worse. And then it also makes the risk higher. You have depression in a person that's having a heart attack, their chances of dying from the heart attack or having a worse heart attack are higher than somebody that's not depressed, right? And if you think about that, if depression really is so pervasive and it's so problematic for other conditions, it seems to me like from a healthcare spending standpoint that we would be way more focused on dealing with it from the standpoint of how do we kind of actually risk mitigate lots of different problems, and how do we actually make lots of different medical conditions better. And so I think that perspective hopefully will, there's a bunch of efforts in play right now to try to show that. Our healthcare system is like financially not set up that well to show that, and we're, surprise, surprise. But I do think that if you can show that, and you show particularly if you can show insurance companies, hey, look, we treat this person's comorbid depression and they get out of the hospital, get out of the hospital a day or two earlier. We know that with like total knee replacements, people get out of the hospital a day or two earlier if they don't have depression. You show that kind of stuff, then maybe you're able to make a difference in, in that experience, and, kind of recognize it as a problematic comorbidity. So.
Wonderful. Nolan, Eric, Teddy, thank you so much. Join me in